Hi, good evening. Thank you, everyone who's joining tonight. My name is Edith Schussler. I'm an assistant professor of allergy and immunology at Weill Cornell here in New York. And I have the pleasure of not presenting, but introducing you to William Ambler, who is a first-year fellow at the Hospital for Special Surgery here in New York. And he's a recent graduate of the pediatric residency at Yale. And as our senior mentor this evening, Dr. Rebecca Marsh, who I'm sure many of you already know and have read many of her publications. But Dr. Marsh is an immunologist and transplant specialist at Cincinnati Children's Hospital. So with that, William, I'm going to let you take it away.
Great. Thank you so much, Dr. Schussler, and thank you, Dr. Marsh, for being an expert on this case. I was fortunate enough to take care of this patient who had a very interesting presentation, which I'm happy to present today. So I'll just go ahead and get started. Our patient is a 5-year-old boy, now 6 years old, who presented with persistent fevers. Initially, he had fevers for about a week, and in February, he didn't really have any other localizing symptoms. He was seen in his pediatrician's office, and he had some blood work done, including a monospot, and had positive EBV serology, so was diagnosed with acute EBV infection and was just had supportive care. He continued, this was kind of late February. By March, he continued to have intermittent fevers, and he had fatigue and malaise as well. And by April, with continuing to have intermittent fevers, he was evaluated by an infectious disease specialist here at Cornell. So just getting a little bit more about his history. He had allergic colitis as an infant, but did well on elimination of milk protein. He only required antibiotics once in his lifetime. He's had normal growth and development. In terms of his family history, his maternal history is Taiwanese and English, and his paternal ethnicity was Chinese and Italian. There was no consanguinity, and there was no history of any immunodeficiencies or autoimmunity in the family. Besides that, he just lived with his parents, and he has 2 younger brothers that are both healthy. So when he was evaluated by infectious disease, his exam at the time was unremarkable. He didn't have any stigmata of malignancy. His labs at the time showed just a mild anemia and mild thrombocytopenia, and his serologies were consistent with acute EBV infection with a very elevated viral capsid antigen IgM, and at that time he had mild elevation of his transaminases, which could be also seen in a mononucleosis-like picture. So they concurred that he had an EBV infection at the time. So just to briefly review EBV, it's one of the herpes virus, which is a double-stranded DNA. It's spread primarily through saliva. It normally initially infects epithelial cells through an unknown mechanism, but its primary the site of infection is in B cells, where it binds to CD21, and it eventually establishes latency in memory B cells and can be prone to reactivation. It's capable of transforming B cells and can be implicated in cancers and lymphoproliferative diseases. Most infections are subclinical, and pretty much all adults are positive for this. It's diagnosed either by serology or monospot, which uses heterophile antibodies, which are the IgG antibodies, which interact with the Hort erythrocytes. The monospot actually has a high false negative rate in young children, so it's serologies are kind of a better way to go. This graph just shows your serologic response to EBV over time, showing that the IgM peaks early as well as IgG, and then your IgG stays there for a while, and eventually you get nuclear antigens, which can help you determine if it's an older infection or reactivation. Kind of continue. So in April, he had some improvement, and then he was able to go back to school, but kind of towards the end of May, he started to have fevers again. And then in June and July, he started to have fevers, high fevers, about twice a week, and had increasing pallor. And that's when he presented to our immunology clinic. So I think at this point, we can just briefly pause and see if anyone has any initial thoughts about this case.
Any joint issues?
No, there's been no joint disease at all.
So at this point, we don't have any questions, other questions. So I think we can go forward with the next part.
Okay, great. So this is our exam of him when he first to our rheumatology clinic. He was afebrile. He might have had a mildly elevated heart rate. Overall, he was a very well-appearing young boy. It was noted that he had just a mild oral thrush. He did have some very non-impressive bilateral shoddy lymphadenopathy. There was no other lymphadenopathy on exam. And the most significant part of the exam was his pallor and significant hepatosplenomegaly. So labs were obtained at this visit, which showed him to be have worsening anemia, ongoing mild thrombocytopenia, a transaminitis, as well as mildly low fibrinogen, a fairly elevated ferritin, normal triglycerides, and his inflammatory markers. His ESR was normal. His CRP was just slightly elevated. His EBV PCR at the time showed kind of a low level of viremia. So just to summarize, this is a 6-year-old with persistent fevers, bicytopenia, hepatosplenomegaly, transaminitis, and hyperferritinemia in the setting of a prolonged EBV infection. So the decision at this point was submitted in the hospital for further diagnostic workup. And so I was wondering if anyone had any thoughts at this point.
Had he been on any steroids or antibiotics to account for the thrush?
So he has not been on any steroids or antibiotics.
And you had already mentioned in the history that he was healthy prior to this, no significant infections up to this point in his life.
That's correct.
So we do have a couple of questions. So there's a question about his retic count, and I'm not sure what and comb. And then, so we'll start with that. Do we have the retic count and the rest of the CBC differential?
I think his retic count was, I think, slightly elevated, around like 5%.
So then, yeah, there's also a question about whether the anemia was Coombs positive or not.
So he did have a C3 positive Coombs. His IgG was negative, and he had a low haptoglobin.
Okay. Were there any developmental issues? How was his growth percentile-wise? Was he small or normal?
He was I think 50% for his height and 25% for his weight. He's had normal growth velocity and normal development.
All right. And yeah, somebody already has a question about XLP. And there's also a question about the soluble CD25 levels and if a bone marrow is done.
Okay. So I think I'll move on because those slides are coming up. So when we initially hospitalized him, our concern was for HLH with his current EBV infection, and our differential include lymphoproliferative disease, lymphoma, or concern for primary immunodeficiency causing a chronic EBV infection. Here are the initial labs that were done. So he did have evidence of hemolysis, and his anemia worsens to a nadir of 5.5, and he did require 1 transfusion, but otherwise he remained very stable. He was neutropenic. His ANC nadir was 400. His ferritin had kind of gradually increased over his hospital stay to a maximum of 8,000. His transaminases kind of gradually trended down over his stay. In terms of his immunologic labs, he was mildly hypergammaglobulinemic at 1850 with normal other immunoglobulins. He did have a low CD4 count with normal CD8 cells. His NK cell number was normal, but he had normal NK cell function and killing, as well as perforin. He had inadequate responses to some vaccines, but not all vaccines. He did have normal SAP expression, which is seen in XLP1, and then he had a normal soluble IL-2. His IL-18 that didn't come back for a couple weeks was markedly elevated with normal IL-1 and IL-6. His vitamin B12, which I think was sent with a concern for autoimmune lymphoproliferative disease, was elevated as well, and it was sent.
So there is a question about stool calprotectin. So,
I don't think the stool calprotectin was sent.
Okay.
He wasn't. Yep.
And the CD25, I think that was sent actually.
The CD25, is that not the same as soluble IL-2?
Oh yeah, sorry, I didn't see your soluble IL-2. Sorry about that. Yes, so those were most of the questions on labs now. So yeah, if you wanted to progress.
This is just kind of turning his hemoglobin, which went down to 5.5, and he was transfused, and then he was able to mostly hold his own hemoglobin, although he continued to be slightly anemic. Infectious disease labs were sent, which were all negative except for low-level EBV viremia. He was able to mount a normal mitogen response in his quantiferin test. To work up, so he did have a peripheral B flow, showed no evidence of B-cell malignancy. It did show elevated CD8 compared to CD4 count, and there was no evidence of lymphoma, and he didn't have increased double-negative T cells. His bone marrow biopsy just showed normal trilineage hematopoiesis, and it did show an increased number of small. And then his liver biopsy, which he had with the bone marrow biopsy, showed a lymphocytic predominant infiltrate, mostly CD8 cells. The B cells that were there were polytypic and EBER negative. And then he did have a PET CT scan looking for evidence of lymphoma, and it showed just mildly avid lymph nodes, mostly were cervical and kind of retroperitoneal, and also his have large splenomegaly. He was overall he was hospitalized for 2 weeks. He was stable the whole time. He was intermittently febrile and just required the 1 transfusion. And he was briefly on antibiotics for empiric treatment for fever and neutropenia. The decision ultimately with a multidisciplinary team was to start anakinra. There was discussion about steroids, but I think there was concern about suppressing his immune system further, and this did cause resolution of his fevers. Overall, lab parameters have been improving prior to anakinra and continued to improve, and he was eventually discharged on anakinra without a formal diagnosis. So the next slide is just kind of showing his fever curve, which showed that he was intermittently febrile. And then once we started the anakinra, he was afebrile.
So we're getting a lot of questions on the differential, and I think that's coming up, so I'm going to hold off for now, asking the differentials that are coming up in the chat room.
Okay. So I thought we'd briefly talk about HLH for people that don't take care of HLH that much. In rheumatology, often we call it MAS, depending on if it's secondary to an autoimmune disorder, and sometimes it just depends on who you see first. So this is the 2004 diagnostic criteria, and the diagnosis can be either with a molecular diagnosis that's consistent with a genetic cause of primary HLH, or if you have 5 of the 8 criteria: fever, splenomegaly, cytopenias, elevated triglycerides, hemophagocytosis, low or absent NK cell activity, and elevated ferritin, and elevated CD25 or soluble IL-2 receptor. So our patient had fever, splenomegaly, cytopenia, as well as an elevated ferritin with no evidence of hemophagocytosis, although there was, I think they sent his slides to NIH, and there might have been some discrepancy between our pathologist and theirs. And he had a normal NK cell function and normal IL-2. So there are inherited HLH, and then there are our primary or familiar HLH or secondary HLH, and then macrophage activating syndrome, which is kind of more of a secondary HLH to autoimmune disease. There's multiple different causes, and there are more and more genetic defects are being discovered. Multiple of them are involved in the perforin Gram-sign pathway and decrease cytotoxic lymphocyte and NK cell killing. And some are highly associated with EBV. Probably the best known is XLP1, which codes for that SAP protein. And then this is just a slide of showing different genetic diseases that are associated with, these are genetic primary immunodeficiency syndromes that are exacerbated by EBV infection, and the ones that are highlighted are also associated with HLH, and other clinical manifestations are things like lymphoproliferative disease, lymphoma, and chronic EBV infection. So at this point, I thought we would pause and see if people have ideas of the differential.
So we do have a few questions on the differentials. So there's been some questions, were we thinking XLP or Castleman's disease or a partial MHC class 2 deficiency? There was a question if we had checked HLA-DR, which I know we did not. And then a question, so on the differential, it's a great differential because it's a lot of what we went through ourselves. So we have XLP, Castleman's disease, XIAP, or NLRC4, or a ITK deficiency. And so this was I'm going to let you go forward with the differential. We had a lot of different groups involved here. So, that image of a elephant where everybody sees what they specialize in the elephant, that was a bit in this case. So, William, do you want to talk a little bit about how the differential was discussed?
Sure. And can I just make one comment?
Sure.
Yeah. I just want to point out, so the UNC13D and the STXBP2, those both very much associate with HLH. So even though they're not highlighted here, I just wanted to point that out. That's all.
Thank you. So we thought he likely had some type of, I think, a primary deficiency associated with kind of an HLH or HLH-like picture, given his labs as well as his low level of EBV. I don't think we could really prove it when we were given that with his normal NK cell killing and his normal soluble IL-2. And so we just didn't have, I think we were waiting for some of the genetics to come back to hopefully give us at this point. But we weren't thinking that he had any type of malignancy given the negative workup, and he didn't have any evidence of autoimmune disease. There was some thought of Castleman's, but and it was technically hard to get somebody to biopsy his subcentimeter lymph nodes, and they thought it was probably fairly unlikely.
Okay, and I'll just add in from the immunology side. We were all sort of leaning towards something leading to HLH, but there were some questions because the labs didn't. The 5 factors that fed into this were not consistent and not there the whole time, although we were leaning towards that. So there was some consideration of other primary immunodeficiencies, especially with the high CD8 infiltration. So we did consider PI3 kinase as well as a few other immunodeficiencies, but highest on the differential was probably an HLH with either primary or secondary, but we were looking for a genetic cause of HLH as our primary goal.
Yeah, and I'll echo that. There would have been other things on my list too, especially because he had a positive Coombs, and then he had really poor vaccine titers, and the thrush. Like you would have also been, looking really carefully and thinking about humoral and cellular deficiencies. And the EBV wasn't super high, right? That could have just been a little reactivation and the setting of other stuff going on.
Right. So even though, HLH was kind of in everybody's mind, there were enough things that were concerning that, we had some of the vaccine titers were not what we had hoped for or would want. And so there was a somewhat broader differential, and is the reason that we decided against going with steroids right off the bat. So all of that did come into the picture. So there is a question that was posted about two interesting questions. One was, would not normal NK cell function make HLH less likely? And I can say we didn't quite understand the normal NK cell function. I will say that we later did find that there was low perforin on a second test, but the initial was it was one of the things that made us a broader differential. And then there was a question about silver hair, and I'll just say basically this kid had nothing other than the hepatosplenomegaly to really notice on his exam. And there's a question about etoposide. So out of curiosity, how much of this workup could be done after the patient's given etoposide?
That I'm not sure about. I might defer to Dr. Marsh.
Did we lose Dr. Marsh? She's coming back on. I will say that she had mentioned earlier when we were discussing the NK function, just to note that in XIAP, the NK cell function is normal. So part of the differential.
My next slide has the diagnosis. Should I move on?
Sure.
He did receive a diagnosis of XIAP, which is also called X-linked lymphoproliferative disease 2. This was found as he was had a pathogenic mutation in this protein. It was discovered on the primary immunodeficiency panel that was sent out. It was confirmed by flow cytometry. This is, I believe, normally one of the tests done when sending a test to Cincinnati for primary immunodeficiency, but I believe the assay was down at the time, which I think delayed his diagnosis slightly. And I think the decision at that point with this diagnosis was to change him from anakinra to steroids, which he also responded well to. So I thought I would talk about the pathophysiology. I found this slide kind of helpful for what XIP is and what it does. XIP is a ubiquitous protein, and it has several different motifs. It does block caspases and allow for cell survival and expansion. I think it's particularly important in T cells and NK cells. And then it's also decreases inflammasome activation, and the NLRP3 is known to be involved, which is involved in secretion of IL-18, which is secreted similar to IL-1. So kind of in this first cartoon, it shows that you have infection, you have toll-like receptors, and your innate immune response activated, and this activates your it activates your adaptive immune response. And these T cells eventually expand and will kill off whatever virus it has and no longer leave antigen for your innate immune response. And then eventually you turn off your immune response, and XIP is thought to be important in that. When you don't have XIP, the thought is maybe you have increased apoptosis of your activated T cells, so you're not blocking your caspases, and then you're having persistently active virus, which is activating your innate immune response, and you're also not, you're getting hyperactivation of your inflammasome and getting elevated IL-18. I thought in this particular case it was interesting that his IL-18 was elevated, which is seen in XIP, but soluble IL-2 normally elevated in XIP, which I thought was a little interesting that his soluble IL-2 was normal. And this leads to HLH and can also lead to a very early onset IBD. So that XIP phenotype is often HLH, which can be kind of mild or incomplete, which is what we saw with our patient with fever, cytopenia, splenomegaly, and often EBV is the trigger. A lot of these patients, or most of them, will get recurrent episodes of HLH. They have splenomegaly. Some of them develop hypogammaglobulinemia, which our patient did not have. And some of these patients will present with a very early onset IBD, and then there are rare things of liver disease, arthritis, vasculitis, but there have been no cases of lymphoma or lymphoproliferative disease described with XIP, which I think in several papers argue that this would be more of a primary HLH instead of a lymphoproliferative disorder. So the prognosis and treatment in different studies, the cell mortality can be up to about 40%. And stem cell transplant can be curative, but seems to for some reason have a high mortality in this group. And there have been some studies looking at reduced intensity conditioning, and I think this is more prominent in Japan, I think, because of the genetic, and they've had some success, although it looks like they've had more patients relapse as well. So for our patients on steroids, other options for him are anakinra, rituximab, IVIG, anti-IL-18 therapy, or no treatment at all, as some patients who have reached adulthood have actually received no treatment. So just back to our patient. His CBC improved. His ferritin is now kind of around 1,000. He hasn't had any more fevers, and his hepatosplenomegaly is almost resolved. And the last I checked, his steroids were weaned to 3 milligrams BID from, I believe it was started on 10 BID. Currently, his team is not recommending stem cell transplant, and his mother and 2 brothers are being genetically tested. This is an X-linked disorder. And we're kind of thinking of other options if he were to relapse, become steroid dependent, things like IL-18 or rituximab. So I thought here we could take any last questions.
Yes, so we're running a little long, but if there was a question on just comparing XLP and what the difference between XLP and XIAP is, especially regarding, I think, lymphoma and the how they differ in lymphoproliferation. I think maybe Dr. Marsh could speak to that.
Sure.
Yeah, so there haven't been any reported cases of lymphoma with XIAP deficiency or XLP2. So, some of us say XLP and we mean to be implying XLP1, whereas we say XIAP for XLP2, but some people really do use, XLP1 versus XLP2. But in XLP2 or XIAP deficiency, we really don't think there's any predisposition to lymphoma. It's really more of an inflammosomopathy the more and more we think about it. And there are more rheumatologic type patients out there too that have some frank arthritis and things like uveitis. And a good clue in this case was really someone just wrote about the IL-18, but an IL-18 of 100,000 is usually only a few things. It usually ends up being XIAP deficiency or NLRC4 activating mutations, or it's the systemic JIA kids with their MAS. Very often those IL-18 levels are very sky high too. And I don't think anything's necessarily published about this, but in some of the XIAP patients that we see, they do have this pattern that it's more of a hyperkeratinemia as opposed to having a high soluble L2. And that's probably reflecting the fact that it's more of an inflammosomopathy, whereas the soluble L2 is a reflection of your T cell activation. So if you're not having tons of T cell activation, you're not going to have a really high soluble IL-2. Now, some of them, once they get into frank HLH, then, their soluble L2s are high, just like everybody else. But in a patient like this, that's not that surprising. And then someone had asked about workup. So you can work patients up for HLH if you need to start treatment, like some of the screening exams, like the CD107A, the perforin, the SAP and the XIAP protein expressions. Those really aren't very affected by steroids at all, so don't be hesitant to start either steroids or anakinra if you need to treat a patient with inflammation. The steroid caveat is be careful you're not going to mask a leukemia, so get your biopsies that you need before doing steroids. But otherwise, it doesn't really necessarily interfere with the testing too much. Etoposide can, because you're actually lysing and killing cells. And usually you want to be kind of really certain. And remember that etoposide is going to target your T cells too. So etoposide is a really good idea when you know that you have a lot of T cell activation. So that soluble L2 can help with that decision.
I wonder if you had any on the decrease response to vaccines in this patient. Is that something that you see in patients with XIAP?
You can. About a third of them will get like some CVID-ish or humoral deficiency hypogam type of stuff. In this case, was it necessarily something intrinsic, or was it just because there's a sort of chronic inflammation going on for 3 or 4 months that sort of burned out or sort of destroyed some of those B cells? That could be. And, the NK cell numbers were low, and time will tell. Like you'll see in 3-6 months from now, like, is the immune system looking more normal? And if you vaccinate him, does he respond to vaccines later down the road? But you should keep an eye on it because, potentially he could benefit from some IVIG, but I don't know that for sure if things might get better just with quelling the inflammation.
Well, thank you so much, Dr. Schussler and Dr. Marsh, and thank you everyone for all your questions. Thank you.
Oh, there's one last question, if I can ask it very quickly to Dr. Marsh. There's a question of what's the cause of the reverse CD4-CD8 ratio?
You see that a lot in patients that have HLH or HLX spectrum diseases. Like it just represents CD8 expansion. Like when the patients are well, they don't really have a reversed ratio at all. So that's another kind of indication that there's a lot of inflammation going on.
All right, and I'm off now, and I'm going to hand it over to Dr. Hartog.
Thank you. So I am Nick Hartog. I'm an assistant professor at Michigan State University. And presenting today, actually one of our patients is Dr. Kamat, who's a PGY3 pediatric resident for us. And then we had a last-second change, and Dr. Marsh is also going to be the senior mentor for our case. She was nice enough to volunteer, so thank you. And then Dr. Kamat, go ahead.
Thank you, Dr. Hartog. So we'll get started with our case. So we have basically our case started in the newborn nursery. We have a newborn male who was born at 36 weeks and 5 days gestation. Was born via spontaneous vaginal delivery, initially no complications and did well, was able to stay in the nursery with his parents. On day of life 3, when he was undergoing just a normal car seat test, he did desaturate and so failed his test. He was transferred to the NICU just for another day of observation since mom had been discharged already. Later that day, while in the NICU, he did have an episode of hematochezia. So workup was started at that time. His platelets at that time were 32,000 with an unknown MPV. So he was treated for presumed neck. Symptoms never resolved. He continued to have hematochezia throughout his NICU stay. They did check an HLA maternal antibody, which was positive, so he had presumed NIAID. He did at that time have a reportedly normal peripheral smear, though this was checked in the setting of multiple platelet transfusions. While in the NICU, he was treated with multiple platelet transfusions. He also received 2 rounds of IVIG. His platelet levels never improved. He was then transferred to our institution for further workup. While he was there, he did have a normal MRE, Meckel scan, EGD, and colonoscopy. He continued to be worked up since he continued to have hematochezia. He had a second scope about a month after his initial EGD and colonoscopy. That scope showed an ulcer approximately 7 centimeters from the rectum. Biopsies at that time showed nonspecific chronic active proctitis, along with focal acute cryptitis and gland loss. He did have another scope about a month later following that one due to continued hematochezia that showed progressive disease. His biopsy that time showed active colitis, and the scope had multiple colonic ulcers along with duodenal erythema and exudate. He had a pretty thorough infectious workup at that time that was normal. He did kind of along with this develop several oral ulcers that would wax and wane in severity. He would oftentimes be unable to eat due to the severity of the ulcers, and he did ultimately develop failure to thrive. Because of the scope findings along with these ulcers and the failure to thrive, he was started on treatment with mesalamine and infliximab. So just taking a look at his colonoscopies, this was his second scope showing the one ulcer near the rectum, along with the biopsies that just shows pretty significant inflammation. And this was the subsequent scope, so his third overall colonoscopy showing multiple ulcers at this point, as well as worsening inflammation on his biopsies. And then an additional symptom that the patient had, he had had dry skin since birth, was diagnosed with eczema. As he was getting older, his skin progressively worsened. It did eventually start to peel and develop scaling. It would often have discharge and start bleeding. He did have a skin biopsy, which was non-diagnostic. So I'm going to pause now just for initial thoughts.
Yeah, so I see one vote for Wiscott Aldrich, which we will definitely get to that. And the anti-enterocyte antibody we did not do at any time with us to send that off. It typically comes back about 2 to 3 months later, so we found it not very clinically helpful all the time. And he did have normal glucose levels also with all of that. And Rebecca's got a nice addition there. Any other questions or thoughts at this point? So yes, and I can tell you between myself and hematology at this point, we were echoing what everyone was saying, which was this was Scott Aldrich. So, all right, Aarti, why don't you go on?
Okay. So he did have an extensive workup. His CBC hemoglobin usually ranged between 8 and 12. The lowest his platelets were 43,000. He had an absolute lymphocyte count that would range between 1,700 and 2,500, and eosinophils were around 1,400. He had pretty persistently elevated ESR and CRP, averaging in the 20s and 10s. We did send flow cytometry. The only abnormality was a low CD3, CD8. His thymic production was all normal. He had a normal newborn screen, as well as normal trek on peripheral blood and normal CD4 recent thymic immigrants. We did send further flow cytometry, which is listed there, all of which were normal. We sent a cytokine panel to Cincinnati. His IL-6 was slightly elevated at 10. Otherwise, the rest of his levels were all normal. He did have a slightly elevated IL-18 count. We did check immunoglobulins as well. His IgG was elevated, but he had received 2 IVIGs, and he was only a few months old at this point, so could also be reflecting maternal levels. And he did also have a normal hair microscopy.
Okay, and then we have a couple questions. Hey, Aarti, why don't you go back one? Just go back to the labs. There we go. Perfect. And so just going through, and one question was about repeating the platelet and smear without the transfusion. So he did end up needing repeated transfusions, kind of varying length of time. So we had that same, no matter how hard we tried, we couldn't get the mean platelet volume from the outside institution. So when we did look at the CBC as far out from a transfusion as possible, so like 7-8 days, the mean platelet volume was normal, and the platelet size looked normal at that time as best we could tell. And then we looked at the IL-18 level, which was slightly elevated there. And then we have a couple. The IL-10 level was normal. We didn't look at the actual receptor level. And then we have another differential that comes up with DOC8 deficiency, and that was definitely on our list of things that could be, along with the NFKBI was also on that, a long list. We don't have any IL-17 levels. Any other thoughts or questions at this point? Or any other labs that people would be looking for, wanting to get at this time? And there wasn't any hepatosplenomegaly. Really, when we looked on both physical exam, there's none of that. We ultrasounded to make sure. And his LFTs, his kidney and liver function were normal. And yes, there was a little bit, the high eosinophils and low IgE. The eosinophils hung out right around that 1,400 range throughout all of his diffs that we could see. That was about where it was average, including the little bit low lymphocyte count was about average also. Okay. All right, Aarti, why don't you go on?
So we're also actually going to pause here for a differential.
Well, yeah, you can go. Yeah, we kind of did that already. We've been talking a lot about it, so we can go on. Yeah, the next slide.
So this was what his peripheral smear looked like when we were able to get a good one. If anyone has additional thoughts.
So, and I will say this was originally read by our pathologist as likely as smush neutrophils, likely a processing defect. Until we looked back. And I see a couple people picking up and saying WDR1. Any reasons why people are saying that? Any of the people that are typing that? And Carl, I see saying calling out the Mickey Mouse neutrophils. All right, and so Aarti, why don't you go on from here?
So we did go ahead and get whole exome sequencing on him, and he had disease-causing variants in 2 separate genes. One was a homozygous deletion in the STS gene, causing X-linked ichthyosis, which would explain his skin findings. And then, yes, he was a compound heterozygote for variants in the WDR1 gene. So, moving on. So once we had the diagnosis, we had already initially been thinking that we needed to move towards bone marrow transplant. With the official diagnosis, we did decide to proceed with that. So at 7 months of age, he did have a 9 out of 10 mismatched unrelated bone marrow transplant. He received reduced toxicity myeloablative conditioning. We used alemtuzumab, busulfan, and fludarabine for his conditioning. He achieved neutrophil engraftment at day 12 post his transplant and platelet engraftment at day 81. He did have quite a complicated post-transplant course. He had veno-occlusive disease, a pericardial effusion requiring drains, TMA, and autoimmune hemolytic anemia. On day plus 88 post-transplant, his IL-18 levels did normalize, and day 125 post-transplant, his scopes showed an absence of ulcers as well as microscopic colitis on his biopsies, and he has not had any further bloody stools or oral ulcers, so is doing quite well from that standpoint. So just briefly talking about WDR1 deficiency, WDR1 gene encodes actin-interacting protein. This actin-interacting protein is present in most leukocytes and is involved in remodeling of the cellular cytoskeleton. AIP1 also regulates actin disassembly, so this allows actin to disengage from proteins and be available for further use. As we know, actin and its supporting proteins have functions in adaptive and innate immunity. It also composes many body tissues, including the brain, muscle, epithelia, and blood. In murine studies that replicated a deficient state, there have been serious abnormalities in several tissue types. In terms of microscopic findings, there's agranular cytosolic regions, nuclear herniation, and impaired chemotaxis and chemokinesis. So this affects neutrophil function. And as a partner protein to actin, it impacts both myeloid and lymphoid cell lines, as well as whole tissue structure and function. It also participates in the cellular junctions comprising the barrier epithelium. In terms of human disease, it presents as a human dysregulatory syndrome caused by actin dysregulation, including thrombocytopenia, impaired wound healing, and severe stomatitis with oral stenosis. Presentations also include periodic fevers, recurrent infection, diffuse autoinflammation, and these can lead to death. And classic for this is the nuclear blubbing of the neutrophils, which we saw earlier. And so how is WDR1 linked to IBD? So the intestinal lining is normally sealed by tight junctions formed by a protein complex that includes actin. During flares of IBD, the lining becomes inflamed and there's increased permeability of the intestines. So with a genetic defect that already involves the actin structure, then the patient can be more susceptible to increased epithelial permeability that's seen in IBD flares. So to summarize, WDR1 gene encodes the actin-interacting protein, which regulates actin. It causes an immune dysregulatory syndrome caused by actin dysregulation, including thrombocytopenia, impaired wound healing, and stomatitis and oral stenosis. Here we have a case of WDR1 deficiency that presented as a very early onset IBD as well as thrombocytopenia. And so far, our patient has responded well to stem cell transplant.
And just go back with a few questions right here. One asking about the peripheral smears they reported as normal initially. And yeah, they were, when we go back and look, they were abnormal the whole time. And it was the official report read that there was smearing of the neutrophils, likely secondary to processing. But when we looked at them, or Hemonc looked at them, they, were saying from the start, this looks like an actin defect. And so I think it was a little bit of inexperience in the pathologist, to be quite honest. I think this is a good example of going back and looking at the smears and things don't make sense. And then was there microstomia or any perforation of the palate? There was not any. He did have a lot of extensive ulcers. One was about 1.5 centimeters in his upper lip, and he probably at most had 8 to 10 oral ulcers. And pre-transplant, we had a lot of trouble controlling his inflammation. We ended up having to use infliximab and steroids at the same time in order to get him to tolerate feeds because he wouldn't suck, and then feeds wouldn't stay down. And so he had really, really extensive inflammation of the whole GI tract that just kept getting worse and worse, but nothing that perfed or no microstomia yet. Did the infliximab and steroids work well? Dr. Marsh, no, they did not. I think they bought us enough time to get the work up for transplant. But our goal was to get him up to 6 kilograms before transplant, and we just barely made it. So it allowed us to get his nutrition better, but I would say his inflammation was never fully controlled. And then going into transplant, we also had him on IVIG, acyclovir, and actually Bactrim too. And then does the microstomia develop over time? And so that's the thought, is the people it's been described in have been older. And so he's actually, being an infant, he's the youngest one that was described. I think the other youngest were 2 or 3 years old, if I remember, in the Pakistani cohort. And so it probably does develop with uncontrolled inflammation over time. So hopefully he won't develop that. And yeah, both the mutations were inherited, one from mom, one from dad. They were not de novo, but this is their first child, and I can tell you they're only now. And then Rebecca, did you have anything to add as far as the transplant? Because one of the things that we noticed in retrospect is going in with all the inflammation is that we did have a lot of complications with the transplant as far as veno-occlusive disease. He had TMA and other complications there. Is that something you'd expect going in with an inflammatory disease such as this?
Yes and no. It's a reduced toxicity prep, and the buflucampath is usually pretty well tolerated. And I think it was the right prep to use because for this disease, you really want good myeloid engraftment that's stable over time. And so just like CGD or Wiscott, I think this is probably a perfect prep to have picked. The VOD is surprising. And, I was looking at Steve Holland's paper just because the one patient was transplanted, but they just say successfully transplanted and they don't go into any details. And so, as time goes on and more patients are transplanted, you may learn that there's a signal there and that there may be some either pre-existing liver damage or inflammation that predisposes to VOD, or because it's an actin defect, maybe there's something intrinsic in the liver that they're more susceptible to VOD. Now, this can also be just dumb luck. One kid in 50 is allowed to get VOD, and so, I'm not sure what to think about that. And TMA, we see a lot of TMA inclusions, but go ahead, sorry.
Oh, I was going to say that, so Steve's patient that they transplanted didn't have any VOD, and neither did the patient in London that was transplanted too. Neither of them had any of that. So,
okay, well, that's
it's an N of 3 now that we know of. So, and
you might have published a series, to be honest. Are there details published about the other two?
No, there's not. That was all personal communication. So.
I mean, it would be worth it if you guys could take the lead, if they would be, happy to collaborate and just publish the little 3% series, because this is going to come up, and basically you guys will be the experts.
And then Carl is asking any speculation as to why the presentation was so early. And so there is a variability among the mutations in WDR1. So a complete absence of WDR1 is fatal and not compatible with life. And so it is a percentage of it. Now, we don't have any functional testing or any more basic science testing on him. And so, but my thoughts would be is that he had a mutation that was more on the severe disease and led to less function overall, but that's just my thoughts. Any other questions? Well, thank you, Dr. Marsh, and thank you, everyone, for coming tonight. And that will conclude our webinar tonight. Thanks, everyone, and we will see you next month.
Bye.
Good night, guys.
Night.